This is the Aortic Dissection Awareness Day was the September 19th, but the whole month is really considered Aortic Dissection Awareness Month now these days, and there's lots of global events and awareness and education events that happen. We chose to hold our event today on September 26th, and we are obviously thrilled to have 4 experts in the field of aortic surgery, cardiology, and genetics to help us build awareness about aortic dissection and some of the underlying conditions that sometimes cause aortic dissection. So I am here with Chris-Anne Campos, who's the Executive Director of GADA Canada. And my name is Lindsay Ruch. I'm the board of one of the board members for GADA Canada. And I'm also a patient. So I come to this with some knowledge as my own life, but also because I've been doing this as a patient advocate for many, many years with GADA and with the CMA, which was the Canadian Marfan Association in the past. So on the next slide, we tend to really highlight whenever we run one of these types of events about the disclaimer. We obviously, it's very important that all of the information presented in this webinar or virtual event is obviously for educational and informational purposes. And obviously GADA Canada, we're a voluntary health organization. We are not specialists, although some of the people on the screen with us are. So, but obviously, none of these medications, courses of treatment, lifestyle or activity recommendations discussed in this virtual event should be undertaken without talking to your own physician or your own cardiologist. You want to keep going, Chris? And so I wanted to talk to you a little bit about GADA Canada. If you don't know who we are, GADA Canada, of course, is a patient advocacy organization in Canada, and we promote a lot of research-based awareness, education, and support specifically for people with genetic aortic disorders, but also general aortic health. And so obviously we're very dedicated, and our mission is to saving lives and enabling a promising future for individuals living with genetic aortic disorders, which could include many different genetics at this point and diagnoses, including Marfan syndrome. And GADA has been supported and doing research in this field for over 20 years with funding from the Temerty Foundation. We also are part of the administrator and one of the founders of the Montalcino Aortic Consortium, which is the MAC registry. We run webinars regularly. We also have been running, obviously during the pandemic, is quite a few virtual meetups so that patients can just connect and exchange their knowledge and their experiences to support each other. We also are part of the Heritable Aortic Disorders Symposiums that run in Canada. We haven't had one for a couple of years, of course, because of the pandemic, but hopefully next year in 2023. There will be another one finally in Halifax, so stay tuned for that. And so we're going to, the sort of general agenda of today is we will hear from our 4 wonderful panelists, starting with Dr. Sarah Thorne. And then we will have an opportunity to have a small panel discussion with these 4 experts. I've compiled quite a list of topics and things that have been submitted by the people who have registered, but also from general topics that are talked about a lot within the aortic dissection community and issues that are hot on top of people's minds. And then there will be an opportunity for you to address all of us with questions. And so after the discussion, we will open it to questions. There is a box at the bottom. If you haven't used Zoom before, there is a Q&A button at the bottom, and you can submit your questions. And Chris-Anne and I will help address those at the end of the session. So hopefully you will, if you have specific questions that come up as far as these talks, you can put those there. So we're going to hand this over to Dr. Sarah Thorne, who's one of the adult congenital heart disease cardiologists and this is a hard word for me, obstetric. I'm sorry, Dr. Thorne. You can, it's just a hard word for me. Peter Munk Cardiac Center in Toronto. So we are very excited to have you talk to us about aortic dissection from the view of a cardiologist. So take it away.
So thank you so much. My video has just stopped working, so I apologize. You don't get the joy of looking at me. Once I've finished talking, I'll get under the desk and see if I can sort it out. So it's a real delight to take part in this meeting today. So thank you so much for inviting us all to speak. I'll share my screen, hopefully that bit at least will work. Okay. So I'm really pleased to talk about diagnosing aortic dissection. And that's obviously the thing that all of us are most concerned about. It's the scariest thing that patients and doctors can think of when we're talking about looking after people with aortopathy. So this is really important. I'm just going to start with a slide from one of the posters from the UK, which ran and still runs a Think Aorta program, where they contact all the emergency departments in the country just to get people to think about aortic dissection when somebody comes into hospital with symptoms. And the bottom line, my talk can be very short. It's think about the aorta, do a CT scan. And the quicker we act, the better the outcome for the patient. Very simple clinical assessment. We have to think about symptoms. Pain, obviously, as we know, is the #1 symptom. And although classically we say it's in the chest, it can be in the back, the neck, or down into the abdomen and be associated with other symptoms too. And the key is it's really severe. This is never a subtle pain. It can be tearing or ripping, but it's severe and sudden onset. When we see somebody, we need to think about whether the patient has risk factors. And if you are somebody who knows you have an aortopathy, put your hand up and say, I've got risk factors for an aortic dissection. I have an aortic issue, so that it makes it easier for the ER physician to think about the aorta. And then we have the physical examination and the diagnostic testing to think about. Just to recap for us all, an aortic dissection is a tear in the inner layer of the aortic wall. Blood flows through that tear and causes a split between the inner and the middle layers, and that's called a dissection. A dissection can be type A, where it involves the ascending aorta, and it can involve just the ascending aorta, or it can involve the ascending aorta, go round the arch and all the way down the descending aorta. A type B dissection just involves the descending aorta. And these are CT scans that will show us so beautifully what a dissection looks like. On the left here, we've got a beautiful 3D reconstruction where we can see that the ascending aorta is dilated and there's a line that runs up through it showing an ascending aortic dissection. Here on this more simple section, we can see the dissection line is running down the descending aorta. Oops, sorry. And in this cross section at the front of the chest where there's a dilated ascending aorta, again, we can see a line. And on the right of the line, the small D shape, that's what we call the true lumen. That's where the aorta should be. And this is the dissected part. And then we can see at the back is the descending aorta. Now, these images are quick to get. We don't need the fancy multicolored 3D reconstruction to make a diagnosis, although they're always helpful to look at. It's a very straightforward, quick test to do that can really be done in most centers. within emergency department. So what about the Canadian experience? We know this mirrors the experience around the world, certainly in high-income countries. So we know that mortality death from aortic dissection increases that by 2% every hour. So it is a time-critical diagnosis to make. And in this study, we found that in a quarter of patients, the diagnosis was delayed by 24 hours after arrival at the ER. And in a third of patients, the diagnosis wasn't made at all at the first visit to the ER, and it was either diagnosed at a subsequent visit or, very sadly, at autopsy. So we've got a lot of room for improvement in thinking about a diagnosis of aortic dissection. The flip side of that is to say that, yes, a CT scan is really the key test, an ECG-gated contrast CT scan, but we have to use it effectively. We shouldn't use it on every patient that walks through the door who's got a bit of a twinge in the chest. If we use it inappropriately, so we're doing it when it's not necessary, we're exposing patients to radiation, we're putting them at risk of a contrast reaction. We may get false positives, so that's where it looks like there's a dissection and there isn't, and so people are getting inappropriate treatment or further investigations. It can result in people ending up stuck in the ER for a longer period of time than's necessary, and it's an expensive test. That's not to say it shouldn't be used, the cost shouldn't be relevant, shouldn't be considered if you think a dissection really is the diagnosis, but it shouldn't be done without thought. What this tells us is that we need to risk assess somebody who comes into the ER and we're thinking about a dissection. And the risk factors, that the way to risk assess is to build up a score system. So we think about, does this patient have any risk factors? Do we know that there's an aortopathy, a connective tissue disease like Marfan syndrome or Loeys-Dietz? Is there disease of the aortic valve? Has there been surgery or a procedure done that involves the aorta? Is there a family history? Is there a known aortic aneurysm already? And you score according to those risk factors. And then the nature of the pain is important. Classically and pretty reliably, aortic dissection is a really severe pain. It has a very sudden onset, and people often describe it as a ripping or tearing feeling that can move, and it moves because the dissection itself is extending. Examination findings can be helpful. There may be a difference in pulse between the right and left arm, or the arms and the legs. There may be some neurological signs if the dissection has involved the neurovascular blood vessels. There may be signs to show the aortic valve has become leaky. That's if the dissection has extended down towards the heart. And the blood pressure may be low, or there may be evidence of fluid around the heart. That's called a pericardial effusion, when the aortic dissection has extended right into the heart. And then we need to think, is there another alternative diagnosis that could well be likely? Personally, I would add an additional risk factor here, and that is a woman who is either pregnant or in the early postpartum period and presents with these signs. We really need to think of aortic dissection. If you look at women of childbearing age who have an aortic dissection, the majority are either around the time of pregnancy or in the early post-pregnancy period. So it's a real flag to remember, and it's often a bit of a vacuum in our ER physicians' minds, that they're so focused on the fact that the woman's pregnant that it doesn't occur to them that they could have something like an aortic dissection. So pregnancy needs to be up there in that risk factor list. And then when you add the scores up, that can help guide you where to go. And rather than just doing the writing I've put up at the bottom, we can follow a flow sheet. If we score 0 on that risk score, then really no further aortic investigations are necessary, and another cause for the presentation to the ER needs to be thought of. If we score high, so 2 or more points, then an ECG-gated aorta is likely to be the right way to go. More difficult group is those who have a score of say 1. And then we need to individualize our decision making and consider doing a blood test called a D-dimer. That's a blood test that we classically use for another condition called pulmonary embolism, but it's also fairly reliably raised in people having an aortic dissection. Note it's not very useful in pregnancy because it's raised in normal pregnancy. So outside of pregnancy with a risk score of 1 and a normal D-dimer, you can probably go be reassured and not do any further aortic investigations. If the D-dimer is elevated, then an ECG-gated CT aorta is likely to be the right thing. I think in this moderate risk probability group, we have to be very much guided by the clinical feel of whether a dissection really could be the possibility. And we would be correct to be fearful of missing an aortic dissection. So the summary, we know rapid diagnosis is crucial to survival. And it's about thinking about aorta, thinking that the diagnosis might be possible. And there are 2 groups of people here. This is our patients and our families who know they have an aortic problem, need to be able to advocate for themselves. Put your hands up and say, I know I have an aortic problem. You need to think of aortic dissection. And we need to educate the emergency medicine healthcare workers to think about aortic dissection. A quick risk assessment and then act to get the CT scan without delay. And I think that is the first step to ensuring the best outcomes in somebody who's unfortunate enough to have an aortic dissection. Thank you very much. That's me done.
Wonderful. Thank you very, very much, Dr. Thorne. Yeah, great. I was hoping we would get the full rundown of diagnosis and what happens when we show up at the ER. So obviously you've covered that very, very well. I also wanted to quickly let everybody know that Think Aorta, the program and the campaign poster that Dr. Thorne showed at the beginning of her presentation, we are actually working on bringing that to Canada. So I am the patient lead for Think Aorta campaign in Canada now. And we will be working with GADA Canada as the sponsoring organization and Dr. Thorne and Dr. Ouzounian to bring that hopefully to Canada and start having these posters across the country in ERs. So of course, if you have any insights, and we will be hoping to, we're going to obviously need help across the country, please get in touch with GADA Canada, because that's how you can reach me. And we'll be working on that campaign. So I just wanted to let everybody know that. And then we'll move along to Dr. Maral Ouzounian, who is the head of a division of cardiovascular surgery at Peter Munk Cardiac Center. And Maral is also the chair of GADA, the professional advisory board. So Dr. Ouzounian will, of course, look at some of the treatment of aortic dissections.
Thanks so much, Lindsay, and thank you again to you, Chrisanne, and all of GADA for creating this webinar and inviting us to join. Really, it's great to hear everyone's perspectives on such an important topic, and our goal is really to elevate it to the forefront of everybody's awareness. So my task is to discuss as a surgeon what the treatment strategies are for aortic dissection. And we'll talk, Sarah did such a fantastic job of covering diagnosis and what it is, but often people are sort of still unclear, type A, type B, what's the treatment strategy and how do we go about taking care of these dissections. But the main thing to remember about how we categorize them is if any part of the ascending aorta is involved, it's a type A dissection. And if the ascending aorta is not involved, if it's only descending thoracic aorta and lower down, it's a type B dissection. So that's very important. And one aspect aspect to remember is, in addition to rupture of the aorta, which is obviously a catastrophic complication, one of the most serious complications of dissection is that blood flow to any organ can be compromised. And this is really just a schematic of all the branches that come off the aorta. This is why the aorta is so important, because it provides blood supply to everywhere, starting from the heart with the coronary arteries, up to the brain and the arms, and then the spinal cord, and lower down the abdominal organs. And when we have a dissection, any of those organs, the blood flow to those organs can be compromised, and how we manage the dissection depends on that. So type A dissections, the treatment is immediate surgery. So anyone with a type A dissection requires immediate open heart surgery through the front. So through a sternotomy, it requires heart-lung machine, and it requires replacement of the first part of the aorta. So this is because we know that with medical management, type A patients with type A dissection don't survive very long. And the faster we diagnose it and the faster we get patients to the operating room, the better we can do. So which parts of the aorta do we repair at the time of type A dissection? So the aorta has various parts. We always repair, meaning we replace. We actually cut the aorta out and we replace it with a fabric tube. We always replace the ascending aorta in a type A dissection. We often replace the root in a type A dissection, especially when there's a genetic condition involved. And at times we replace the whole arch with the branches to the brain and the upper body when necessary, but always the ascending aorta. So this is the minimal repair for a type A dissection. And as I said, this involves open heart surgery, heart-lung machine. We cut out the torn aorta close to the heart. We replace it with a fabric tube. It's made out of Dacron, and we stitch it in at the top and we stitch it in at the bottom. And at minimum, we replace the ascending aorta in everyone with a type A dissection. Often, if the root is not involved, we can save the valve by resuspending it. But this is the minimum operation for acute type A dissection. Now, the root could be large, it could be dissected, it could be really extensively destroyed by the dissection, or it could be aneurysmal. And as I said, in genetic patients with a genetic cause for their dissection, often the root is involved and root replacement is necessary at the time of surgery. And there's two options here. Either we do a valve sparing root replacement, that's the Tyrone David operation or reimplantation of the aortic valve, or we replace the entire root with a prosthetic valve, either mechanical or tissue valve. But when we say root, it means the coronary arteries are involved. It's this whole initial segment of the aorta. And so the valve and the coronaries are dealt with, have to be dealt with when we replace the root. At times, on the other side of the ascending aorta is the aortic arch with the branches to the brain and the arms. And at times, the entire arch may have to be replaced. And again, this happens if there's a large tear in the arch, or if the arch itself really has a very big aneurysm, and sometimes in other conditions where we have to replace the arch at the time of type A dissection. And this is a more extensive operation, and it requires rerouting the plumbing to the brain and the arms. And it can be done either through a conventional elephant trunk technique, or this one where there's a stent in the descending thoracic aorta. This is a hybrid total arch, and it's called frozen because this one is stented compared to this one where the graft is just hanging in the descending thoracic aorta. So sometimes arch replacement might be necessary at the time of acute type A dissection, but this does increase the complexity of the surgery and the time on the heart-lung machine and the time where the brain may not be getting adequate or normal blood flow. And so although we've done a lot to make this operation safer, we typically do not replace the whole arch unless it's really necessary. So type A dissection, once you have emergency surgery, which, everyone presenting with an acute type A, almost everyone requires immediate emergency surgery. Even after successful repair, it's very, very important for us to remember that the rest of the aorta is still often dissected. Almost always the dissection, when it happens, the entire aorta tears in a type A dissection. And so we cannot replace the whole aorta at a time. So we replace the part that is potentially fatal at the time of the dissection, which is, as I said, at least the ascending and sometimes the root and sometimes the arch. But this residual disease, the rest of the dissection that's there, that has to be followed forever and really requires lifelong monitoring of the entire aorta for forever. And this is regardless of if you have a genetic cause for your dissection or not. Everyone who's had an aortic dissection needs lifelong imaging of the entire aorta. So shifting gears a little bit, what about type B dissections? So type B dissections are almost always actually treated medically, and type B dissections we can categorize them into uncomplicated or complicated. Uncomplicated means that there's no signs of rupture. The organs are all getting perfused. The pain and blood pressure are well controlled, and there's no strong reason to intervene in this situation. Most patients with acute type B dissection actually do well with medical therapy. That means very strict control of the blood pressure. We often will put our patients in the ICU with close monitoring and control of the blood pressure, and then very close follow-up with scans in short sequence to make sure things aren't changing and that the aorta is stable. And with medical management, most people do well with a type B dissection. Some people, though, present with a complicated type B dissection, particularly those with where the aorta is at risk of rupturing, either impending rupture or free rupture, or where the organs are not getting enough blood. And in this situation, we do have to intervene in acute type B dissection. And there's two options, either stenting or open surgery. And endovascular repair is for sure the primary mode of treating acute type B dissections. It's really shifted in terms of how we manage it. But patients with hereditary aortic disorders with known genetic conditions, we often don't, historically, we haven't wanted to use stents because there are issues with stents in genetic patients. The aortic wall is just more fragile. Where we're landing at the top end and the bottom end could be diseased aorta. It can leak, it can rupture, new tears can be created. So we use it with caution in patients with genetic disorders. However, if you are there with an acute type B dissection and there's a life-threatening emergency that can be saved with a stent, then for sure we do. And I would say that this has been increasing in recent years, including in patients with a genetic disorder, really to get them to get our patients out of trouble in the acute setting. Otherwise, the option is for open repair, and this is very extensive surgery, and it's often high-risk, complicated surgery, and it could be any extent of the aorta, either just in the chest or the entire thoracic and abdominal aorta that has to be replaced. And this is, we try not to do this operation in the acute emergency setting, but sometimes in the setting of dissection, if there's an underlying aneurysm or a young patient with a hereditary aortic condition, we do have to do these operations in an emergency setting, and these are the options for what we do at that time. Again, once you get over the acute situation, again, everyone with a type B dissection also requires lifelong monitoring of the entire aorta. So to summarize, I would say, and Sarah really summarized that part really well. It's a sudden and potentially catastrophic aortic emergency is what acute aortic dissection is. Acute type A dissection requires immediate emergency open heart surgery with replacement of at least the ascending aorta and at times the root and the arch when necessary. Acute type B dissection is often treated medically, but may require emergency either endovascular or open repair of the thoracic or the thoracoabdominal aorta. And survivors of dissection do require lifelong monitoring of the entire aorta, ideally in a dedicated aortic clinic. So thanks so much. I will stop there and hand it back to Lindsay.
Wonderful. Thank you so much, Dr. Ouzounian. I know there's always lots of questions, and obviously, you know, there's very specific questions related to people's own experience. And there's a few in the panel discussion that are more general about surgery options and I think especially living after a surgery like that. So I do think hopefully we can address some of those in our panel discussion. And so, but we are going to move on to Dr. Milewicz, who obviously, you know, if you end up with a surprise dissection, they're all a surprise, I think. But, you know, without a genetic disorder, or you may already feel you have something, but you don't know what it is yet. Obviously, Dr. Milewicz is the expert of genetics related to aortic disease. So we're very excited to have Dr. Milewicz go through where things are with the genetics and causes and research related to genetic disorders. Dianna is the president of the George H.W. Bush Chair of Cardiovascular Medicine, the Division Director, Professor, and Vice Chair of Medical Genetics at the University of Texas Health Science Center at Houston. And Dr. Milewicz is the Executive Chair of the Montalcino Aortic Consortium. Thank you, Dianna.
Thank you, and thank you for the invitation to talk this afternoon. I'm going to be talking to you about the genetic predisposition for thoracic aortic dissections, and then also how we are moving into a gene-based management or precision medicine for this condition. So I've been working many years to try to identify all the genes that predispose someone to thoracic aneurysms and dissections. And the reason why I've really focused on this disease is because these aneurysms that form in the ascending aorta tend to be totally asymptomatic. People don't know they're there until they do something life-threatening, like an acute aortic dissection. And the data is pretty devastating in terms of what happens to people with dissections. The best data we have say that 50% of them never make it to the hospital. And then we've already heard about how it's a medical emergency if somebody does make it to the hospital. And the reason why I wanted to work on this disorder is that if we can figure out who's at risk, we can image them for these aneurysms, put them on medications to slow the growth, and ultimately go in and repair the aneurysm to prevent the dissection. And you can change the outcome of the disease completely if you know who's at risk. And so I've been working on trying to identify all the genes in the human genome that are altered to predispose people to this disease, to aortic dissections. And this is sort of just an overview about what we know about the disease. At this end, we have people that have inherited or are what we call have new mutations in a single gene in the human genome that confers this high risk for an aortic dissection. And it's been known for many years that there was a risk in individuals with Marfan syndrome. And we actually published in the 1990s that if you properly follow Marfan patients, instead of dying of dissections in their mid-40s, they have pretty much a normal life expectancy. So that was really the nidus for me to go on and try to find all the genes predisposing people to the disease. We now know there's other syndromes that are distinct from Marfan syndrome, including Loeys-Dietz and some others. where they have similar inherited predisposition with syndromic features. But we also know that the majority of people that have an inherited predisposition look completely normal. You can't pick them out from the general population. And I just showed John Ritter here as somebody that is an example of that. And so we wanted to go after all these high-risk genes, and it accounts for about 20% of the disease. So 1 in 5 patients that have a dissection will have one of these high-impact genes. And we also think that people, the other 80%, which tend to have later onset dissections and no family history of the disease, they have genetic variants that predispose them, and then it's either a genetic, 2 or more genetic hits coming together, or some of the other risk factors like long-standing hypertension that triggers the dissections in these individuals. And we're working on those genes, but I'm going to really focus in on these really high-risk genes. So I've been working at this for many years, as had some other labs around the world. The majority of the genes in this list have been identified by my lab, I'm happy to say. And now you can get genetic testing of all these genes worldwide, and genetic testing is available in Canada. And despite knowing all these genes, we can only explain the disease in about 30 to 40% of the families. So we still have a ways to go, and our sort of, a calculation is that there is going to be about 100 genes and another 100 genes in the human genome that can be altered to predispose to this disease. So we hope to have an answer for every single family that's participating in our research study. And many of those come from Canada. So if you have had genetic testing, it's negative, and you have a family history, please contact me, because we'd love to recruit you and your family into our study. So we've known for a long time how to manage Marfan patients. This is the top gene up here, FBN1. We've known about the aortic complications of Marfan syndrome since like the 1950s. A lot of work has been focused on defining the disease. And we know how large we can watch that aorta grow before we go in and repair it. And as we started finding some of these other genes, we realized that we couldn't watch the aorta grow that large before we had to go in and repair it. And it appeared that for almost every single gene that's on this list, there were differences in the way that the patients, the age of onset, what they tended to present with, whether it was a type A or a type B dissection, and what size we could watch their aorta grow to before we had to go in and repair it. And it became obvious that we needed a lot more data on all these other genes to really be very efficient and effective in preventing aortic dissections. So that's where the Montalcino Aortic Consortium was launched. And I am incredibly grateful to GADA and the Timberdy family for funding it, and very grateful to the aortic centers worldwide that are participating, but also all the patients out there that have agreed to share their data, de-identified, so we can put all this data together and really come up with precision medicine for every single one of these genes. And I'm quickly going to go through, we've published many papers from the Montalcino Aortic Consortium, and I'm going to quickly go through just some of the highlights and what it's starting to tell us about the disease gene. So this is just a graphic of the Montalcino Aortic Consortium that we're collecting. The clinicians and scientists are collecting all this data. We put it in, and what we want out is data that comes back to you and your family members that are at risk, so that once again, we can prevent any bad outcome like a dissection or a rupture. So we looked at the first 1,000 cases, a little bit over 1,000 cases, and looked at these genes here. and started to explore the age of onset of an aortic event. And here they're grouped. These affect the smooth muscle contractile proteins. And these genes down here are those Loeys-Dietz genes that affect TGF-beta signaling. So these are the time to event, and we define an event as going in and repairing one of those aneurysms or presenting with the type A or type B dissection. And so here's the smooth muscle cell genes, and here's the Loeys-Dietz genes. This is the age that somebody came in with that event, and this is the number of patients that have had an event by that certain age. So if I go over to these Loeys-Dietz genes, right away, you can see the age of onset when you go from gene to gene is significantly different, with TGFBR2 being the earliest onset and SMAD3 being the latest onset. But then if you look down here and you look at childhood events, you can see with TGFB2 and SMAD3, there's no childhood events, where there are childhood events with the TGFBR1 and TGFBR2 genes. So this tells us a lot. This tells us a lot at what age we need to start watching people for disease. And it means, you know, kids with SMAD3 or TGFB2 mutations, we need to probably do baseline imaging and maybe check them every 2 to 3 years, but we don't really need to worry about the bad outcomes in childhood. Whereas with TGFBR1 and 2, we do. And the same story is over here with the smooth muscle genes. PRKG1 is the most early onset, and in fact, of all the genes we studied, this had the earliest onset of disease. Here's ACTA2, and then here is myosin light chain kinase, which has a much later onset of disease than any of the genes. And just one more note, so we have a gene like TGFBR2, and we have this spread of onset that occurs where it's from childhood all the way up into late into the 60s. Well, we asked the question, if you actually look at the actual change in the gene, does that make your prediction even better? And that was the case. Here's the recurrent variants in TGFBR2. And here's all the mutations in green shown here. But here's one mutation where essentially all the children with that mutation have an aortic event before their 20th birthday. And at the other end, there's this one out here, the black line, which is another mutation where nobody has an event until their late 50s. And there's still people out in their 80s that haven't had an event yet. So we can even be more precise in the actual gene and go down and look at the individual variants within the gene. So we can be very precise. Like if we have a child with this mutation, we're going to be aggressive about managing them, about imaging them, and so on. But a child with this mutation, we may have to be a little bit more aggressive because there was a child with an event. But typically the events are really not occurring very significantly until the age of 20. And I just want to say that it also, each gene will tell us what to expect down after the aorta is repaired. And for the LDS genes, we have to worry about aneurysms and dissections elsewhere. For a gene like ACT2, it's completely different. We have to worry about early onset strokes and early onset coronary artery disease, completely different vascular disease. And the Montalcino Aortic Consortium is really trying to understand the triggers for those events associated with ACTA2, but I'm going to show you some information about the arterial events in the LDS patients. So here's those aortic events with some childhood events with TGFBR1 and 2. But here's the events in other arteries. And so that's arteries outside the aorta, this in the brain, the arms, and the stomach area, and so on. And you can see in our cohort that nobody had another arterial event before the age of 20. And then once again, TGFBR2 is the earliest onset of events, but they're not as common as these aortic events. And once again, we're defining event as surgical repair of an aneurysm, dissection of the artery, or rupture of the artery. So these are not just picking up aneurysms that are small enlargements. These are things that need surgery. And I want to say that we looked at all the cardiovascular risk factors to see if there was anything that correlated with these aortic events. And what came out as the major risk factor was smoking. And so I just want to get that out there, that smoking really increases your risk for these other arterial events if you have LDS. At least that's what our preliminary data find. But there's another group that's working on this also that found the same results. So I'm fairly confident this is a risk factor for the disease. So just to summarize that we want to use genetics to prevent dissections, but also to define the management of the gene. And anybody with Marfan syndrome, a family history of thoracic aortic disease, or anyone with a dissection under the age of 60 or aneurysm repair under the age of 60 really needs to seek genetic counseling and testing. If the disease-causing mutation is identified, we should go to medical and that precision medical and surgical management for the patient. And if we haven't found the gene in a family, then everybody at risk needs to be imaged. But we're also recommending, and have been for the last 12 years, that if you have an aneurysm or have experienced an aneurysm or dissection, that all your first degree relatives should be imaged for those asymptomatic aneurysms. So that's your parents, your siblings, and your children. So thank you.
Thank you, Dianna. It's amazing work, and it's just, obviously very excited for me to know that people like you are doing the work you do for people like us. So thank you very much. And we are also now going to spend a little time with Dr. Michelle Keir, who is based in Calgary, a cardiologist at the Orthopathy Clinic at Libran Cardiovascular Institute. And we've asked Dr. Keir to talk about topics that are a little bit more sort of pre and post surgery, and some of the issues that we also find, living with, for example, a genetic aortic disorder, or living with post-surgery. You may not have known you were at risk to an aortic dissection and then suddenly have one. And so now obviously you're living with aortic disease. So we're very thankful to have Michelle with us. And thank you, Michelle, and take it away.
Perfect. So I'm just sharing my screen if that's okay.
Yeah.
So hello, everyone. Thank you for inviting me. I thought that I would mostly focus on exercise because I think that's the #1 question we get post-dissection. And really, this is for post-dissection recovering from surgery and also those living with heritable thoracic aortic disease who may not have had a dissection but are at risk. So I'm going to talk a little bit about the evidence for exercise, what the current recommendations are, and what our knowledge gaps are about what we should be recommending. So I think this was really important to always bring the patient voice into it. So both of these patients were from focus groups with congenital heart disease patients, but those with aortic conditions who did have lifting restrictions. And so the first one is, with my condition, I can't do heavy weightlifting. That's been hard. So this is a young man in his 20s. And he felt that he would have liked to have known that earlier on in life. So I think the point of this one is that really counseling can't begin soon enough in these patients. And then the second one is really speaking to, I think, the difficulty of kind of conflicting information and what recommendations mean in people's real lives. So there was a learning curve of learning restrictions. He was working construction, and the cardiologist said that was too physical. So now he works at the airport. So really speaking to saying, be physically active, but don't be a construction worker. So, what are the limitations, and really what are we asking patients to do to protect themselves, but also to maintain physical activity? So this is a paper that I thought was really good. It was a qualitative paper looking at patients with Marfan syndrome living with heritable thoracic disease in Norway. And they did long form interviews with these patients about all of the factors that go into their decisions about choosing physical activity and exercise. And I really like the diagram on the right because I think it really speaks to how complex this issue is. So from the physician side, we tend to focus on the left-hand panel, right? So, what does your aneurysm look like? How long ago was your dissection? What are we going to be doing about what's your weight limit lifting restriction? But I think there's lots more that goes into it, and that kind of is shown in the right-sided panel. So all of these restrictions have significant effects on people's self-esteem, on your social life, your coping strategy. If you were using physical activity, if you're a marathon runner and now you've had a dissection, it's not just the medical event that's changed your life, your whole life has changed, right? So I think this is really important as to how complex all of our recommendations are post-dissection or once you've been diagnosed with a heritable thoracic disorder, and how difficult it is for patients to kind of incorporate those recommendations into their daily lives. The things that they found was there was a frustration and really a grief at the time of diagnosis, because once you're diagnosed with something that doesn't fit with the cultural paradigm of what your age is, there's a real coming to terms with that means. A lot of people commented on and we've had this in our congenital heart disease focus groups, is that, a lot of people say, this is what the restriction is, this is what you shouldn't do, don't do this, don't do that, as opposed to really saying, this is what you should be doing, and these are the things that you can do instead. Patients often get contradictory advice. So your family physician, your surgeon, your cardiologist may all say slightly different things. And even slight differences really led to confusion about what patients should be doing. And I thought this last statistic that they found was really interesting. So a third of patients felt that they were in denial. So they didn't heed any activity recommendations. They just did what they were doing before. 1/3 avoided all exercise because they were terrified by the recommendations. And then a third tried to work within boundaries. So I think that really tells us from the physician side and from the healthcare system side that we're not really providing good, meaningful advice to patients because they're not able to follow the recommendations. So this was a patient of mine who is not supposed to be lifting heavy weights, but he said, I want to go to play college hockey and I need to get bigger, which means lifting heavy weights. I'm not going to lie, I still do it. I'm going to get bigger, but it's going to take more time. So this was upsetting to me because clearly I'm not frightening enough to scare this kid into stop doing the heavy weight lift, stopping doing heavy weightlifting. But I think it really, people's values and preferences and their choices are different. And so we can give a recommendation, but really it's up to that person to figure out how they're going to incorporate that into their life and how they assess risk, right? So looking at activity restrictions in aortic disease. So where is the evidence? What evidence do we have? So this is the classic drawing from the Jack paper that really shows the type of activity and breaks it down based on dynamic component and static component. And so in patients with a prior aortic dissection or an aortic disorder, we're trying to avoid the kind of the y-axis there, the increasing static component. So you want to avoid things that are high static component or even kind of in the moderate range static component. And really the goal is to do physical activity with dynamic component, but again, being careful about the ones with the high VO2 max on the far right there. And again, avoiding anything where you're going to have hits to the chest. So I think the best part about this is all the little tiny crosses and stars on there. So they're all ones that you can do, but don't get hit in the chest, right? And I'm from Calgary, so I think the idea of doing rodeoing with a heritable aortic disorder is terrifying. And that's why it's got both a star and a cross. So these are kind of the guidelines that we give to patients. And again, there's a lot of nuance there. So what do we know that exercise does to blood pressure, and what do we think that does to the aorta? So the reason we want to avoid those really static activities is because they increase the blood pressure significantly. And after a dissection, the Canadian rehab guidelines say the goal blood pressure, even at peak exercise, should be less than 160 millimeters of mercury. That's your systolic, or the top number of the blood pressure. So doing a maximal hand grip with even just a small device increases your systolic blood pressure by 50 millimeters of mercury from what it was at rest after only just 1 minute. Doing it about 30% maximal strength increases it by to 20 to 30 millimeters of mercury. So this tells us that doing normal daily activities, we actually have these blood pressure spikes that we may not appreciate. What about doing heavy weightlifting? So the reason that we suggest avoiding this is because heavy weightlifting, so 90% of maximum lift, causes a significant increase in blood pressure in a short period of time. So for somebody who is normotensive with a systolic blood pressure of 130, with a max lift, they get up to a systolic blood pressure of 230 millimeters of mercury. And so we think that even for a short period of time, over the long term, that can have a detrimental effect. The other thing is the similar blood pressure increase was observed with lower weights with repetitions to exhaustion. So I think the recommendation is that if you're getting to the point where you're really exhausting yourself, your blood pressure is spiking right at the end. And so patients with genetic aortic disease or post-dissection should be stopping their physical activity well before exhaustion. And then also Valsalva, so straining, holding the breath, increases the blood pressure even further than this. What about aerobic exercise? So looking at kind of walking, jogging. So walking briskly for about 5 kilometers an hour gives you about 3 metabolic equivalents, and your systolic blood pressure increases from 120 at rest to up to 160 millimeters of mercury at rest. And so that's kind of what's advised for patients with a prior dissection or with heritable aortic disorder. When you jog, that blood pressure does increase significantly. So the thought is that per metabolic equivalent, so jogging is about 10 mets, walking briskly is 3, your systolic blood pressure increases by about 8 to 12 millimeters of mercury. And so what is the trade-off? So we know that frequent aerobic activity overall does decrease your blood pressure. So does the temporary increase in blood pressure associated with running or jogging counteract the effects, or mitigate the effects of the overall blood pressure lowering on the patient's long-term outcome? So what about exercise? So there isn't really a lot in the way of human studies, but there is this one really nice study looking at exercise in mice with Marfan syndrome. So in this model, aerobic exercise of 30 minutes per day did show a significant improvement in elastin fiber organization and fragmentation. And both forced and voluntary aerobic exercise increased aortic wall strength and reduced aortic dimensions compared to sedentary mice. So I think that the end recommendation is that avoiding heavy lifting, avoiding isometric or that static activity, but being sedentary is also worse. So looking at really doing that kind of brisk walking multiple times per week, higher aerobic but lower static activity is really good for the patient with post-dissection or heritable aortic disorder. And so these are some recommendations that have been published. And again, they're based on each disease, but they're not as specific as we would like. So I think we're moving towards, as Dr. Milewicz has said, more precision medicine. And we're getting there with respect to when you should have prophylactic aortic root repair surgery, but we're not really quite there yet with respect to the significant recommendations for patients. And that's kind of the future, is we can say, well, this is the gene you have, you've had a dissection or you haven't had a dissection, this is what your risk of doing this particular activity is. And so now a lot of the lifestyle recommendations are really quite general. And I wanted to put this up because I think this is important. So this is Isaiah Austin. So he is a young man with Marfan syndrome who played NCAA, so college basketball in the United States. And 5 days before he was drafted to the NBA, he was diagnosed with Marfan syndrome. And so because of that, he was excluded from play. So you can imagine the effect that that had on his life. But then he continued to play overseas professional basketball. So what's the right decision here? And I think the important point is that yes, we can make recommendations, but for each person, it's a personal decision that they have to make based on their assessment of risk and benefit and what's valuable in each person's life. And I think us keeping that in mind when we're making recommendations is really important. Other things, so I think Dr. Milewicz commented on this. So things that we counsel people about after an aortic dissection or once they're diagnosed with a heritable aortic condition. So substance abuse, so smoking for sure is not recommended. Unfortunately, I have a lot of young patients who never smoked cigarettes but are vaping because they were marketed to when they were young teens. And so I think really reiterating that that is also not a good strategy for someone with one of these conditions. Alcohol, so we want to avoid binge drinking because it increases the blood pressure significantly. IV drug use, I think we've all seen patients who've had endocarditis or infections on their artificial material in the heart. So, what is your risk of infection post? The other things we always talk about, so medication adherence, so things like anti-impulse therapy, so beta blockers or angiotensin receptor blockers or hypertension medications. And a lot of patients struggle with this post-operatively because it does affect how they feel and what their exercise tolerance is. And so working with people to kind of come to terms with what their limitations are. I think we're going to talk a little bit about this in the chat, and really it requires an entire talk, but pregnancy considerations and counseling. So if you've had an aortic dissection or diagnosed with one of these disorders, what does that mean? And I think this is something that can't be focused on enough, is the psychological impact of having an aortic dissection. There's really good research showing that even just being in the ICU for a few days can cause medical post-traumatic stress disorder. And I think we really just haven't examined what the long-term psychological impact is on our patients of having a dissection, and then having to continue to engage with the healthcare system for their lifelong care and what that means for their families as well. So I think these are all additional lifestyle considerations that we talk about in clinic and are important to patients. So I'll stop there.
Wow, yes. Thank you, Dr. Keir. Those are exactly the things, you know what I mean, that patients and doctors are, trying to find the answers for. And it is a process. And I think we're learning more and more about the long-term living with these types of events and disorders. So I'm hoping that, I don't know if Dr. Thornton's video will work, but hopefully we can just have a quick chat. We're already at an hour, 15 minutes, which is what I kind of expected. But I'd like to take about at least 15 minutes to address some of the things that I've sort of compiled before the event and based on some of these topics. And then we'll address the questions directly that we have in our Q&A. So obviously, I'll go back to the beginning in a way, which is the surgery. And there's lots of research going on, and there's lots of great aortic research happening. And I know that there has been more talk about concerns with type B dissections after someone who's either had an aneurysm and a type A repair, or they've had a type A dissection and a repair. And is that something that we're starting to learn more about as a risk, on top of the genetic aortic disorder itself as an issue?
Thanks, Lindsay. That's a great question. I think that there's two sort of different categories for where this a distal aortic. So anything sort of past the left subclavian, we can call distal, meaning sort of farther away from the heart.
Mhm.
So there's two different categories where the lower part of the aorta can be affected by dissection. One is after a type A dissection that initially the dissection involved already the whole aorta. And so that is actually probably the most common time where after a type A dissection and the first part of the aorta is fixed, the root, the ascending and so on, then we have to follow the arch and the thoracic and the abdominal aorta for aneurysmal growth. And then they may require more surgery based on size later on. That's probably the most common scenario. But what can also happen, and what we've learned a little bit about, is for although type A dissections can be predicted based on size a little bit, not completely, but a little bit. So if you have a large aneurysm close to the heart in the root or the ascending, we know that elective surgery, a planned, scheduled operation is important to prevent the type A dissection. Unlike type A dissections, though, type B dissections don't have that same kind of predictability based on size. And it's a conundrum for us. It's actually something that we're actively researching. We have to be able to understand a little better why type B dissections are occurring, because the lower part of the aorta doesn't just sort of dilate and then dissect. That's quite uncommon. But what we do see that sometimes patients who have had an elective operation for the root or the ascending, sometimes that can actually change the force of the blood that's hitting onto the wall of the aorta, because there's a stiff graft and things are changing, that sometimes there might be an increased risk of type B dissection if you've had the first part of the aorta repaired. Now, that's probably not the most important factor. Probably blood pressure control is the most important factor for type B dissection. And I'd love to hear the other panel's opinions on that. But for type B dissection, likely the best way to prevent is blood pressure control. And for type A dissection, probably following the aorta for size and having a scheduled elective operation when it hits a certain size. And the numbers, of course, are different based on the gene and based on the family history and based on the size of the patient and so on. But having an elective operation, if the aorta is large, is likely the best way to prevent a type A dissection. Dianna, would you agree?
Yes, I agree completely. One thing I want to say that most of our data that say that people that have that repair of an aneurysm, they're at risk for going on to have a type B dissection, comes out of Marfan patients. And so we don't know if it applies to the patients with other gene mutations yet. We just don't have enough data, and hopefully we'll be able to figure that out fairly quickly with MAC. Now, those Loeys-Dietz genes, most of them don't, the patients tend to present with ascending aneurysms or type A, and rarely the first presenting event is a type B dissection. But with ACTA2 and PRKG1, about 30% of the patients are presenting with that type B dissection. So remember, it doesn't have to be sudden onset of sharp pain in the chest. It can be sudden onset of sharp pain in the back. Fortunately, and there's no way, as already mentioned, that we can actually predict these. But the good news is they're not as deadly as the type A dissections. And we do have a lot of ways to manage them, including non-invasively, as already talked about.
Thank you. So I wanted to then follow up with, and this is just staying on the sort of more surgical topic, is obviously those living with risk that they know about. They either have family risk, or they know they have a genetic aortic disorder. Obviously, people like to ask the question about what are my alternatives if I don't end up with a dissection, but I have an aneurysm when it comes to open surgery. And we know that people see things in the news about new techniques, and so I just wanted you to address that, Dr. Ouzounian, if you can, about what's potentially coming, or what are things that are you looking at as options to make surgery a little, obviously open surgery is important for certain, you know what I mean, especially emergencies. So if you could comment about that would be helpful.
Thanks, Lindsay. Aortic surgery is changing a lot. And of course, everybody would like less invasive, less traumatic, less sort of large operations to go through for sure. Unfortunately, until we have a really good safe way to do really like endovascular or really minimally invasive aortic repair in our patients with genetic disorders, open surgery is still going to be sort of a cornerstone, especially in the elective setting for the aortic root. We can make the surgery a little bit less invasive, make the scar a little smaller, but anything in the root close to the valve, close to the coronaries, requires heart-lung machine and replacement of the aorta. Now there is, there's pairs, there's some wrapping, 3D mesh wrapping techniques, and but like the data is still quite preliminary. And I would say for large aneurysms, aneurysms that are already at a size that could rupture or dissect, I personally am not confident in recommending that. I don't think we have enough data. I would go for the tried and true, cut the bad aorta out and reimplant this valve and save the valve to prevent the valve from also failing in the future. For the lower part of the aorta, things are evolving, and we know if you have already some surgical graft material somewhere in there that can be anchored, where the stent can be anchored before and after, then maybe endovascular is an option in genetic patients. And actually we do that. If you have a false aneurysm or an intercostal patch aneurysm or something else, but there's Dacron there securing it, it's a good option. But it's unusual to have just an isolated aneurysm with no dissection in the lower part in an elective setting. So we're not quite there. And then the branches make things a lot really complicated once we are having to manipulate wires into the kidney and the bowel and the arch vessels. The risks are different and the risks change, but they're still quite substantial. Yeah.
But the good news is that graft that you put in to repair the dissection or the aneurysm, it lasts forever. Yeah, and that's I think that's just amazing.
It is. And patients often ask that question, when does the graft have to be replaced? Just like when we talk about artificial valves and a tissue valve, sometimes, the tissue valves don't last. And so we have to think about the next operation. And I tell them it's, the fabric, the graft itself does not degenerate. There's no problem with it. There's no immune reaction. There's no rejection. There's no, inherent need to replace that graft. We have to monitor it, make sure there's no surgical problem that arises at the valve or the either end of the surgical repair, but the graft itself doesn't deteriorate. It'll just it just stays. That is quite amazing. Back to DeBakey sewing them on his sewing machine, and unfortunately we don't have to do that anymore, and they come in a box, in a sterile box.
Mm-hmm. So I did want to ask a question specifically about ACTA2 patients who obviously have ACTA2 and they've been diagnosed. Outside of the aortic cardiovascular risk, there's lots of other, artery risk in the ACTA2 body, so to speak. And about management and monitoring of those patients. I just wanted to know what info you guys have about that.
Because the ACTA2 story is rather complicated. So the majority of the variants that we find throughout the gene all the variants that we find throughout the gene that are pathogenic or disease-causing variants cause aortic aneurysms that can lead to dissection if the aneurysm's not repaired. And like I said, there is also a pretty significant number of individuals that present with a normal ascending aorta and a type B dissection. But there's certain variants as we go through the gene that predispose to early onset coronary artery disease and atherosclerosis in other vessels. And then there's other variants that predispose to a condition called Moyamoya disease. And that's where the carotid arteries are wide open until the distal end of the internal carotid artery goes into the brain. And in patients with Moyamoya, that gets blocked or occluded, and the blood can't get through. And that's where the strokes occur. And this can occur in ACTA2 patients very young if they have one of those specific variants. But it's just a few variants that lead to the Moyamoya-like disease. And there's just a few variants that lead to the early onset atherosclerosis. And we've set up, we've been working for the last, 8 years on trying to figure out how just one gene can cause all these different vascular diseases. And we have a series of papers coming out this week. And so we can be very precise in terms of which variants will lead to the 2 other vascular diseases. And for those people that have, that in ACTA2 families that have either the arginine 149C variant or have a family member that had coronary artery disease at a young age without risk factors, and I'm talking about 30s, 40s to 50s, that we have data that going on a statin will really help prevent the disease. And even though ACTA2 has nothing to do with cholesterol, it still comes back to cholesterol because it's atherosclerosis. And that in our model system, we can prevent the atherosclerosis with the statins. So we're going to be coming out with a very strong recommendation that those patients with the variants that predispose to atherosclerosis, that they start a statin at a young age and continue on the statin the rest of their life.
Very good. I don't know if Dr. Keir or Dr. Thorne have any comments about managing patients with those with ACTA2 or at all, because obviously, there's just it's a second level of worrying about other parts of the body, you know what I mean, in a way for those patients. So.
And I also want to mention, we've been working on the Moyamoya disease, and I'm hoping that we have a clinical trial for the patients with ACTA2 that have these mutations that cause Moyamoya disease, because we do have a drug that is preventing the disease in an animal model. So okay. Really excited about both of these findings.
Yeah, very good.
And I was just going to say, I think just recognizing that it's a multi-system disease, that this is not a one system disorder. And so, making sure that if the patient has respiratory symptoms, we're referring to respirology, that we're getting neurology involved, if there's stroke-like symptoms, that we're monitoring for coronary disease, et cetera. So I think really just recognizing that this is not something one person can manage in their office, and multiple specialists need to be involved is important, and referring early as well, I think is helpful for patients.
Absolutely.
Thank you. And I wanted to, obviously I'm very conscious of time, but I wanted to know if Dr. Thorne or Dr. Keir or anyone would like to just address sort of complications during pregnancy, again, around aortic dissection. And obviously that could be for someone who has a known aortic risk, but also someone who did not know they had a risk and ended up with an event. And often that is how they find out that they had a genetic aortic disorder or a heritable disorder. So I'd really like to just spend a little bit more time on pregnancy. Obviously I'm very conscious of those stats that you shared, Dr. Thorne, about people who are turned away from the ER 30%, I think it was 30% from the first instance, and just arming patients and also the general population about making sure that they can advocate for themselves as strongly as possible, especially when you're young. I think it's a challenge, and it obviously if you're also pregnant and it is causing an issue to the pregnancy. So if you could give me some insight there, that would be wonderful.
Yeah. I'm so sorry about the lack of video, but
No worries.
I'm still here. So I think that the risks are really the highest for women who are not known to have a problem before they get pregnant. If we know there's a problem, there's an aortopathy, then all women who have the potential to have a pregnancy need to be seen by a specialist who will proactively discuss the risks of pregnancy and even things like pre-implantation genetic diagnosis, which will protect the unborn child from potentially from having the same condition. But assessing and optimizing her condition before she gets pregnant, and being sure that the woman and her partner understand the risks of a pregnancy and how and where they are safest to be looked after, and how we're going to monitor her during her pregnancy and individualize her care plan around the time of giving birth. All of those things we know are really helpful in reducing risk. And sometimes we'll ask Dr. Ouzounian to replace the ascending aorta prior to a pregnancy if we think that the aorta has got to a point where it would increase the risk of pregnancy. And of course, that depends on the rate of change of the size of the aorta, on the particular genetic mutation, on a whole load of different factors. So it does really need to be individualized. But the risk for a woman when we know about it and she's being looked after by a team who understand her risks is going to be lower than the woman who was not known to have aortic disease before she became pregnant. And from the UK maternal mortality data, which I've had a lot to do with over the years, most of the women who very sadly die were not known to have had an aortic problem before they embarked on their pregnancy. And the issue then is that the first we know about it is that acute presentation, and that presentation will be to the emergency room, not to a specialist. And that's why this Think Aorta campaign is really aimed at the emergency room physicians. And you don't expect a young woman who's either pregnant or who's just had a baby to have an aortic dissection. I do, but most people won't. And it is about raising that awareness. And we have from for the messages for care that we produce in the UK for the maternal mortality reports, one of the ones that really I think is important and upsets me is that a woman leaves her baby at home that's at 3 weeks of age and goes to the ER at 2:30 in the morning with severe pain, and somebody writes in the chart that they're tired and emotional and sends them home. Of course she's tired and emotional. She's just had a baby. And one of the symptoms of aortic dissection, because it's so terrible, is agitation and anxiety. So just kind of raising that level of awareness so those really sad errors don't happen is where we're at in the maternal in the maternal health care setting.
Oh, absolutely. So, that's obviously why as soon as I got wind of Think Aorta campaign and its success in the UK, that I was like, we need to do that here, and we will, you know what I mean? I'll do my best to champion that and get that rolled out, and with your guys' help, of course. And Dr. Thorne, it would be, of course, I'll ask you later, but doing a full webinar on this topic as well would be very, very helpful. So, you know,
I'm smiling and nodding.
yes, okay, great, because we'd love to do that.
We can see you smiling, Sarah. Yeah, it's such an important. You know what Sarah said about being followed in a team, it's trying to, especially if in the setting when trying to address this when you're contemplating pregnancy rather than when you're already pregnant. It's super important. And just to just for awareness that it's not just during the pregnancy, but also in that fourth trimester, that early postpartum time period where the risk really does still remain high. So high alert, high awareness. And that is, you know, very upsetting what Dr. Thorne describes about, you know, the being sent home from the emergency room. And this is why these webinars and the Think Aorta campaign are so important.
Yeah.
And can I just add one thing? I think I was thinking about this last week because I have a patient who's got Lewy-Dietz syndrome and is in her third trimester of pregnancy and is followed by a team and made an informed decision and is a really informed patient. And she went to an emergency department in rural Alberta, and we're lucky that all of our notes are on the system so they could see all of that information. And she had severe new onset back pain, and she said, I need a CT scan. And she refused to leave until they did the CT scan. And they actually paged me at midnight because the emerge doc said, well, there's radiation. And thankfully she didn't have a dissection, but I think if she would have been sent home if she hadn't have really advocated on her own behalf and said, no, you have to, I don't care if it's midnight, you page my cardiologist. And I was happy to take that call. So I think a big part of our role too is educating our colleagues, because there is such a big cognitive bias against assuming something sinister like an aortic dissection in a young woman who's pregnant, even if they say, here's my genetic results, here's my note, here's my document from my cardiologist. So I think there's a lot of work to be done for us educating our colleagues. And I think also patient advocacy is so important. It saves lives.
Yes.
And it's so difficult to advocate for yourself when you're, particularly the postpartum women who you're not necessarily feeling at your strongest. It's difficult. So patient advocating is really important, but we can't rely on it because
it's very
we're human, and when you've just had a baby, you're not really going to be on the same form that you perhaps are at other times.
Yeah. So absolutely, and of course, this is why that I volunteer my time to do this, because I've been on both sides of the patient and also trying to help other patients advocate for themselves. And it is incredibly important. It's almost like a skill you need to learn when you have aortic disease as well, is how to do this in a way. And it's you know what I mean? It becomes part of your ethos to keep yourself well and taken care of. So I did wanted to address exercise, because this is why Michelle Kier, you focused on this as much as you did, because yes, it's like every other question that comes in is usually often exercise related, and for good reason. I grew up telling not to do anything. I played in band. I didn't, do anything much else, but luckily I learned how to stay well and exercise within my boundaries. I was one of those third of people who figured that out in my 20s and was able to, do exercise that worked for me in a very safe way, and hiking and all of those types of things. But I do agree that it's scary and it's hard to figure out and navigate without, it's guidance from your GP and your cardiologist, but also seeing other people who live healthy lives within these disorders that they already know they have, or they found out they've had after a dissection. So I do think there is work to be done about we almost need to highlight more case studies of people who know how to exercise within their boundaries, and that it is still fun, you know what I mean? And you can still get where you need to go. So obviously the big one that comes up a lot is weight bearing exercises. And you've generally addressed that quite actively in your speech. So I'm very happy about that. I just wanted to know something about people who are living with type B dissections that are being medically managed. And I know obviously they're on a lot of medication to keep the blood pressure down. They're not feeling necessarily at their best to begin with. What can people like that do to keep themselves well, in the sense that, maintaining muscle tone, just keeping themselves, because I think there's a mental health element to that as well, keeping themselves going if and when they do need another surgery, because the more well they are, the better. So I'm just wondering if you guys can comment about that.
I can comment. I think that, it's underestimated how much just getting up and going outside and going for a walk 30 minutes a day at a brisk pace can really do for someone's overall physical health. I have a lot of patients that swim because they find that it's not weight bearing, it's a low impact exertion, but it's a high aerobic activity. That was a real challenge during the pandemic when a lot of the facilities were shut down, but a lot of people have been able to do that now. And I think really lifting light weights, lots of repetitions, but low weight is important. But really, I think that you're exactly right that the mental health benefits of exercise, and then also if people know they have another surgery coming down the line, we don't want them to acquire those other secondary cardiovascular risk factors that come with inactivity. So really just, I think walking, swimming, light weights, you can't underestimate the benefits of doing those kind of on a daily basis.
Yeah.
Michelle's absolutely right. I think that more of an issue is encouraging people to take some exercise rather than saying you must not do anything. I think the other thing that's really important, not with our patients who've already have a dissection, but for those who are sort of in the slightly lower risk groups, is to think about the individual factors. If you put me in a canoe, it's going to be pretty low impact. I'm not a very competitive person. And it's about the individual and how they undertake the exercise. So finding out, I think for me, finding out how the individual is going to participate in a particular sport is just as important as what the sport is. If it's being done in a fairly gentle way, then perhaps we don't need to be quite as limiting. So as well as saying what sport do you want to do, find out how they're going to do it. And if they're going to be competing in the sort of university first team at something, that may not be such a good idea. It's their internal competitiveness and the competitiveness within any team or league that the person might be in that is almost as important as what the exercise is.
Yeah, I always say, go out cycling, go for a bike ride, but don't be in the Tour de France. You're not trying to win an Olympic gold medal with, everything you're doing. Just kind of take it down a notch and just bring it slightly lower. And I think really encouraging exercise is actually very, very important for our patients. And I think we've gone sort of the other way and people live in fear and on the couch, and overall it's just much worse for their psychological and physical health. And we'll know more about this. There are ongoing studies which are going to be very, very important to actually get us some data to guide the guidelines instead of, some people sitting in the room and making some decisions based on no data. I do tell patients that what really we are trying to avoid is holding your breath and straining, that feeling, that Valsalva maneuver, and really if you're pushing a car off a cliff and that feeling of holding your breath, that is what we're trying to avoid for the aorta.
So for almost all cardiovascular conditions, the data says that doing exercise lowers your risk of bad outcomes from those diseases. And so I think if you need to get up and exercise, but there are studies ongoing that are going to ask the question, will that exercise actually slow the growth of your aorta? And that and I suspect they will be true. And you will be surprised if you go out and start doing those 10,000 steps a day, how much your blood pressure will come down. And so just for many, many reasons, bringing that blood pressure down, the being able to slow the growth for your mental health, exercise is good.
Okay, so obviously we've got 15 minutes left and we'd like to address some of our live questions. We've got 10 here and I'm gonna invite Chris-Ann Campos, our executive director, to help me with those. If you did send in any questions when you registered or now, and if we don't get a chance to respond to them, of course, at any time you can email GADA Canada, which is info@gadacanada.ca, and we are happy to reply and get those answers for you and try and also include those in future webinars, because I do think, especially, you know, as I said, there are certain topics that we need to do more than once. They are very specific, and you know, whether it's psychological support, dealing with fear and anxiety. We've done a couple of those meetups before, and I do think there's something that we should do regularly, because patients, you know, it's not always the time that you're available. So let's do those again. And then things like exercise, obviously the pregnancy and family planning for people who are living with had previous dissections or genetic aortic disorders. So, and if at any time, if you come up with an idea of something you'd like to see a new webinar, or there's, you know what I mean? We're obviously connected to lots of these amazing specialists, and they're, you know, always very willing to help us and run webinars and get you guys information. So please reach out for that. And so, Chris-Ann, do you have questions?
Yeah, so I think this has come across in the chat as well as in the Q&A, as well as people have reached out to GADA several times. And I know Dr. Milewicz's group, the MAC, is trying to work on this topic, which is the variants of unknown significance. So, you know, when people have a gene mutation, but it is a variant of unknown significance, and they have a risk to aortic dissection, or they've had an aortic dissection, what are the guidelines for then monitoring them, or, you know, following up with these kind of patients for their management and care?
So when you get back the results from genetic testing, it can be that there's no changes in any of the genes identified. It doesn't mean, if you get that result, it doesn't mean you don't have a genetic trigger. It most likely means that we haven't identified the causative gene yet. And so you still, if you have an aneurysm and you were tested, you still need to follow up with that aneurysm. And then another result can be that you have a pathogenic variant, what was previously called a mutation in a gene. And that means that you have that alteration. You could have passed it on to your children, so they need to be checked. Your siblings can have it, your parents can have it. So the doctor or a geneticist will go through who needs to be tested. And then you yourself, if you have that pathogenic variant, need to be followed the rest of your life for aortic disease and any other problems associated with that variant. And probably the most frustrating thing to get back is a variant of unknown significance. And that means we found a variant in a particular gene, but we don't know whether it's disease causing or not. And if you get back a VUS, you have to treat that as a negative result. We cannot use a VUS to look and see who in your family is at risk. So if you have a family history and you've imaged everybody in the family potentially at risk, then you probably need to go back and do that again in another 3 years for the middle-aged to younger people. But check back with your provider, because I really think we'll have a major breakthrough in the next few years in trying to take all those VUSs and determine if they're disease causing or not. For not just aortopathies, but for genetic diseases in general.
Right. Right. Thank you so much, Dr. Milewicz. I think, there was one question about a gene that was not addressed in this talk, the FBN2. Is that gene also at risk of people carrying a gene mutation in the FBN2 gene, at risk of aortic dissections, and just overall management and care for these mutations?
So after the work that my group and other groups did to find FBN1, we found that FBN2 causes a condition called Beal syndrome, or a very long name, congenital contractural arachnodactyly. And those patients do not get aortic disease. We were able to show that some of the children and young adults will have slightly enlarged aortas, but they don't grow as they get older. And we have never had a patient with an FBN2 variant have a dissection. So we, at this point, do not think that it is a gene that has a high risk of thoracic aortic aneurysms and dissections. It does look at, they do have a lot of the skeletal complications of patients that Marfan patients have.
Right. Great, that's great. But I think the other question that came across several times was the use of drugs and side effects or complications of feeling certain nerve pain with the use of drugs. What advice would you have to give for patients who feel a certain way after they've been put on certain medication? I think it's the losartan that has been expressed to have certain nerve pain, being associated with nerve pain. I open this question to everyone. Is what advice or what should the patient do or approach their doctor if they're experiencing certain complications or side effects from a change in medication?
I would just say, I think the most important thing is to address it with your provider, because there are always lots and lots of different options. So, I also take care of a lot of young men with beta blockers who have side effects of mood issues and sometimes erectile dysfunction. And, the worst feeling is when you saw somebody a year ago and gave them a prescription and they said, well, I took it for a week and it gave me a side effect, so I stopped, and they never called, right? Because there are always other options, and we always want to work with people to figure out, what works with them. We want to reduce the risk without significantly affecting their quality of life. And so I think really just being honest with your provider and talking with them and saying, I can't tolerate this medication, or this one gave me a side effect. Can we try something else? Because there are lots of options. So I think I would say just addressing it with your provider is the most important.
Right.
I wanted to ask a quick question from the Q&A, which is developing arrhythmia after dissection and repair surgeries. Is that common post-surgery, Dr. Ouzounian? And is that something to be super concerned? Obviously, it needs to be managed, but is it a common complication?
Arrhythmia after open heart surgery is quite common. Happens overall about up to 25-30% of the time. It can be more common with valve surgery, and we see it quite commonly in aortic surgery. Usually, if you follow people along for the few months after surgery and they're well treated, we treat them with initially rhythm and rate control. And if the arrhythmia persists, then we have to use a blood thinner for at least a period of a few months afterwards. But if you track people's rhythm after open heart surgery, usually, you know, after a few weeks, it's already down. And then after a few months, it almost always goes away. And so if it is a concern in the short term, we have to manage it properly. But in the long term, after open heart surgery, it doesn't, it usually resolves.
And this is another interesting question. Is there any research on the long-term mental and cognitive effects of open heart surgery and the use of lung heart machines? I don't know. It's more just about, is there any research about that?
Yeah, it's a great question. Thanks, Lynn, for posting it. You know, if we could avoid the heart-lung machine, we would. Certainly, we've seen there's an association with depression. Some people can have mood changes, cognitive changes early after surgery. Frankly, there's there's a lot going on to optimize the pump, but in terms of what we can do in aortic repair close to the heart without the heart-lung machine, right now we're stuck with a heart-lung machine, I would say. Most of the effects they do resolve over time, and young, healthy people without brain carotid disease or underlying brain conditions, most of this does resolve with time. The delirium goes away and the effects of the pump do go away. Sarah, do you have any comments? You've seen a lot of kids on pump, and then you follow them in the adult congenital world as well. Any comments on that?
So mostly people who've had their surgery as children have done very well without obvious cognitive impairment, and can be very high achievers. Obviously, there are people who've had complications where there has been a brain injury, but that's really pretty rare, particularly in the current era. So it's always a balance of risk, isn't it? That you're right, you don't want to use a pump if you don't need to, but the risk of not going ahead with surgery is going to be higher. And I think whatever procedure you ever contemplate having, it's always a risk-benefit equation that you have to put in place. And in cardiovascular surgery, the stakes are high, the risks are high, but the benefits are high as well. And I think the pump is just part of the risk that we have to consider. And the advances in neuroprotection over the years is significant. So there is nothing that's no risk, but it's that the risk benefit equation that you have to look at.
Yeah, exactly right. And I think this is why it's so important for each person. That balance is very individual. It should be individualized, and if it's a very extensive, complicated surgery, and the risks are very high, we will wait longer. The benefit has to be there as well, and the risks without surgery. It's always a balance for each person. But the heart-lung machine is something that we calculate into that equation in the discussion, and it should be discussed with the surgeon and the cardiologist when we're contemplating surgery.
Okay, so we are at 2 hours. Thank you so much, first of all, to our experts, Dr. Ouzounian, Dr. Milewicz, Dr. Keir, and Dr. Thorne. I know that was a long session, and I really appreciate you giving us your time. It's exceptional. And so valuable to learning more about aortic dissection and all the different aspects that are affected. So thank you very, very much. If we did not address somebody's question or comment, we will do our best as GADA to reply to you via email, and feel free, of course, to email us anytime. Thank you for joining us. You can always find more information at gadacanada.ca. We're also at Aortic Disorders at Facebook and Twitter, and on Instagram, it's GADA Canada. And I really hope that this information has maybe saved some lives, or at least made sure someone went to the hospital when they, you know what I mean, knew enough and were able to advocate for themselves. So that's obviously why we do all of this. So thank you very, very much for all of you.
Thank you very much. And I also want to say quite a few people have expressed an interest in enrolling in MAC. GADA will be in touch with them to put them in touch with MAC. Dr. Milewicz, thank you.
That's great. It's really the only way we will understand these genes more and understand how we can help this whole help all of our patients and everyone in this community. So thank you everyone for inviting us, for coming, and for joining. It was a real pleasure to be here.
Thank you, everybody. Thank you. Bye-bye.
Thank you.
Bye.